introduce Dr. Chih Luan Lin. Have I got that right?
Yes.
Okay. He is an emergency physician from the Department of Emergency Medicine at the Changgung Memorial Hospital at Taiwan, and he holds many positions there. He's the chair of the Committee of Clinical Toxicology and Hazmat of Taiwan Society of Emergency Medicine. And he's been with us for these past 2-3 days, and he's been taking some sessions, and really like his approach to clinical care and diagnosis. I like the analogy of the identifying the trunk of the elephant. And as a physician in the emergency medicine, I think it's critical to get a quick diagnosis. And some of the approaches that he's sharing with us has been an interesting learning process, and we'll have him here this morning to introduce us to the simulation for poisoning and for the Indian scenario as to how we can adapt it.
Okay. Thank you. I'm Dr. Chih Luan Lin from Taiwan. Okay, I'm an emergency physician, so I work in emergency physician. And I think about 10 years ago, when we start to work in the Society of Emergency Physicians, then we try to find some way to teach our residents, because there's no formal toxicology education in medical school. So when I was a young resident, I feel I know nothing about the toxicology, and all I learned is from my resident training. But I have only 1 month run in the Taiwan Poison Control Center, so the learning is not completed. It's just pieces and pieces. You can put the whole things together. So I learned. Of course, we all learn from patients, right? Right. But it's not, we cannot just learn from patients. We should set up our own thinking process of how to diagnose and how to treat the patients. So I learn from books, from references, from conferences, from many other experienced talks. Okay, and when I become an attending doctor, then I was participated in the toxicology patients in my department. So, and I and my colleagues in the Taiwan Society of Emergency Medicine, in the clinical toxicology committee, and we begin to think, what are we going to do for our residents, for our emergency physicians in Taiwan? And we decided to start a training course. Okay, so I'm going to tell you how we started this training course and what it already done. Before the simulation training course, we have an old school type training course. It's just like the lecture. So I think 10 of us, we write the book first, and it took almost 4 years to complete all the books. And this is the 3rd version now. This year we have the 3rd version, and we make lectures according to the content of the books. So it's a 2-day course, and with many topics, and every topics just use 20 minutes to teach our residents. So it's just a brief talk, but makes the resident have a foundation of the knowledge of toxicology, so they can know everything. Of course, it's not easy to get everything understand. in just this short 2 days course. Okay, so my resident always tell me that they feel toxicology cases are difficult because it is not familiar with them. Okay, so after the courses, I and my colleagues in my department, we decided to have another course to get deeper and to get more practical, that our residents or my colleagues can be trained to face the patients. So we decided to use the high-fidelity simulation to be the tool of teaching. Because you can interact with the mannequin, and you can interact with the patient. The mannequin is the patient. With the you can interact with patient's family. You can, just as we do it as real as the real world, so that our residents can get familiar with how to diagnose and make the management. So I'm going to tell you some concept of this. Okay, and I think we already demo a case yesterday. So maybe we have some feedback today. Okay, so what is patient simulation? We create experiences that mimic the real-world conditions to achieve our educational goals. This is what high-fidelity simulation looks like. When you put a trainee or put a resident in a situation or in the emergency department in a ward, it looks like a miss, right? That is a miss, right? So you don't know where you are, and maybe everything is strange. Okay, just when I arrived in India, I have to look something, maybe I'm familiar, something that I can understand. For example, I have to look where the washroom is. It's a critical point. So we have to need to teach our residents what is the critical point. So, okay, this is maybe what we look like now. But we give an environment that is as possible as real, that we may encounter in our daily practice. And we give an interactive mannequin. So this mannequin can tell you what you need in the diagnosis and in the treatment. So I think the concept is well developed now. You know, I think it's the robot. Yes, in Japan or in somewhere in the world, in some country in the world, they use it's a robot or android. They tell you how to do something else, right? So we use the interactive mannequin and to provide the information. So, and we also have a facilitator to help the whole scenario to go smoothly and help provide information for our trainees. This may have our trainees have further coming, but we also need an instructor. An instructor, he can directly show how the case should go on. Okay, and these cues are informations or is a reminder of our trainees. This is the important symptoms or the important signs or the important evidence of poisonings that can remind the trainees, our students, to collect the information that needed for diagnosis or treatment. Okay. So can you get me what I'm already talking about? Because I know that pronunciation may be quite different. So if you cannot understand what I'm talking about, or you cannot get me, please raise your hand. Okay. So this is what we are actually doing in Taiwan. This is the environment. So it's just like the same lab you already have in here, and we decorate the restaurant as like the emergency department. Okay. Of course, I visited your emergency department yesterday. I think it is not easy to decorate as the real emergency department like that. But we should let our trainees know this is the emergency department. This is the setting, so they can know how they should be act. Also, you can decorate the environment as a ward or in ICU. Okay, just as you need. Okay, and two trainees there. Okay, this is the interactive mannequin. The mannequin, you say, can talk, but also you need to make some makeup in mannequin. Trauma patient need to be to make up, okay, but not just trauma patient. Can you tell me what's the diagnosis here? Pardon? We do some makeup. We do some makeup in the mannequin. So tell me, what have you seen? What you see here? What did you see here? The signs? Yes, I think somebody have already knowledge. Speak out loudly. Yes, cyanosis, right? Cyanosis, right? And you see the blood? The blood is chocolate brown. Something everybody likes. So the diagnosis may be methemoglobinemia. Good. So you have to do all of these things. Okay, these are socks. And my assistant, my secretary, they use something to make up the nails and put it on the socks. Okay, so we use all of this to facilitate, to help our residents recognize to recognize the toxic drug. And also you see a nurse there, and we call it almighty nurse. Why almighty? Actually, I don't think not use almighty, but mighty nurse, because he or she provide everything our students should know, and he give cues, get information, direction from the instructor, and provide everything. And he give drugs, okay, and give cues, give clues, okay. So the mighty nurse, the facilitator, actually is quite important person in the whole training courses, okay. And instructor in the control room to see all of these things going on, okay. Also, we have two displays. One shows the signs of vital signs, okay, and we have another display to display maybe chest X-ray, EKG, or gas data. Okay. So put all of this together, then we can have our simulation training goes on. Okay. So, comment or you want to know about this? Okay. And So we have our first simulation course, we call it TSTC. T means toxidrome. Okay, so this is a toxidrome simulation training courses. And we teach our residents just two things. One thing is how do you to collect clinical symptom signs to form a toxidrome. This is diagnosis. Okay, and we tell them you have to look for the vital signs. You have to look the yes. Okay, you have to look for the organ manifestations. Okay, that's one thing. And the second thing is we teach our residents. You have 4 treatment options to treat the patients. Okay. So that's our first course. And the second course is we designed to teach how to use antidote. So we call it ASTC, Antidote Simulation Training Courses. And you see, there is the 4 options of the treatment: supportive care, decontamination, antidote, and enhanced elimination. Everything is on a template teaching. So everything is standardized. So this will make our resident has to help them to build up their thinking process in diagnosis and the treatment. Okay, they can know what information they should to obtain from the patient or from the books. Okay. So every scenario is standardized. We have these starting points from history: who, why, how, when, where, what, and also we have to set up the environment and the mannequin. Okay, and make some makeup. And we have to check the checkpoints in the training process. The checkpoints the residents should know. They should learn from the teaching cases. Okay, maybe it is the recognize of the patient's condition. Maybe if the patient, our resident cannot have the diagnosis, we use Q. Q means some information provided by the facilitators. For example, we use the vomiting, the vomiters from the patient yesterday. And we use the margin of garlic to form a garlic smell in the scenario yesterday because it's organophosphate poisoning patient. Okay. And also, we have to set up the stop point. When the resident is doing very well, doing good, then okay, we can just smoothly to stop the point. But if the training works badly, then we will tell the facilitator, do you need a consultation from toxicologist? Okay, and we will hand a handphone to the trainees to help him not to be frustrated, but he still can learn from the cases. Okay, so this is for this child of I know it's written in Chinese, but I want to show you some components. This is start point 1, who, when, where, the history part, and this is starting point 2, the history. The vital signs and some makeup. Okay, and several checkpoints there, and the stop point, when to stop, and this is the cue. You see, in this case, in this teaching cases, we have 5 cues, multiple cues to help our residents to learn. Okay. after the case scenario, and we'll have the debriefing. The debriefing is we let our resident have the chance to practice, so he or she is planned how to have the diagnosis and try it out on the mannequin, right? And he will get experiences from the training courses, from the cases, so he knows something really happens. And this experience will have some reflection to him. And what happened in a scenario? And this will have some more conclusions. Why did it happen? And have feedback. So this is the positive feedback. What happened in our resident's mind when he or she is taking the courses. Okay. And so we have this debriefing. Yesterday, I already showed you this debriefing can be happened between observers and the students. The observers, they sit beside the scenarios, and with checklist the observer have the observers knows and observe the students doing. What are they doing? They are put in the same radio frequency, so they are thinking the same thing. The observer can observe what the resident did well or what the resident do not take the right action. So they can discuss each other. Okay, so this makes not just the resident to learn, but also the observer has built up his thinking process by using this learning cycle. Okay. And also I have a small tools for our debriefing. You see, this is tool, something like when we were young girls, I think young girls, we put the different courses into the body, right? Do you have that kind of toy? No? No, okay. Maybe I'm too old. Okay, so when you have occupied patient in our cases, so we can put the meiosis pupil into here, and you can put the first bar here, and you put, if the patient is depressed, you can put the depressed over here. So you can form a toxicology. Okay. And this is going to be done in our debriefing section. Okay. And also, we can have structured feedback, okay? Just like we already showed you yesterday, we have the checklist, okay? Okay. And after the discussion, the debriefing with observers, we have a 5 minutes mini talk, and this is a standardized core content to summarize all the cases and the important issues that we should know in the poisoning cases. Okay. All the we can also use video-assisted debriefing. Everything happening in the same lab is recorded by video, and then we play it back and stop it in somewhere and have some talk. This also can be used. It depends on what do you want to know, what do you want to use. Okay. So the debriefing, this is the checklist, okay. And also you can use in a non-technical skill checklist, especially for team resources management, okay. But I think the TRM learning is not our main objective in our simulation training courses, but it can be used here. Okay. For example, I have used TRM training course in another patient transfer courses in Macau. This is confidence rating before and after. Before the courses, our residents, they feel just middle level of confidence to manage the poison patient. But after the courses, they feel quite confident. Okay. And also they have gained some knowledge. Okay. This is the test before and after the courses. Okay. And with quite a certification, the yellow bar and the blue bar is the very satisfaction and the satisfaction. Okay. Okay. So this is our teaching experiences. The day after 2060 have studied here. When we started in 2030, and we have trained over than 300 trainees in TSTC courses and over 100 trainees in ASTC. I think now the number is doubled today. Okay. And we also have some international experiences. We have a workshop in Asian Conference for Emergency Physicians. Okay. And this is, we were invited to have this in Macau. Okay. To deliver courses in their annual meeting. Okay, that's okay. So, comment, suggestion, and questions.
What strikes you about Dr. Chih is his enthusiasm. So when he found that we were interested in developing toxicology training, during my visit to Taiwan, he said, "Would you like to start the TSTC course?" I said, "What is TSTC?" So then he started explaining, so then I'll come to India and teach you all how to do this thing. So he's that kind of a man, you know, he's very generous and wants to share what he knows. And I think the key bit when he started was that it should help in training and it should help in patient care. So we've been having discussions over the last 3 days how to version this course for our setting. So these are some thoughts, and we want your help and support to see how to take this forward. So this is the idea, how to develop a course which is appropriate for India in the Department of Medicine, along with Changong Memorial Hospital and the Taiwan Society of Emergency Medicine. So like he said, our objective is to train physicians, and I think that we all know that the general physician is very important in managing the poison patient, the emergency physician, the critical care physician. All of us require to identify the toxidrome, to provide the emergency treatment, the in-hospital care, and the 4 treatment approaches in toxicology that he already mentioned. So we thought we should design this course around our MD students, like the second year, but also for emergency trainees as well as critical care fellows. So what does versioning the course for India mean? So we know that toxicology is dependent on where you are, and the poisons in UK or US and the poisons in India are different, as poisons in Taiwan are different from poisons in India. The principles may be same, but the actual disease is very different. So we thought we'd design the course around the common toxidromes that he mentioned, plus specific poisoning approaches that are required for India. For instance, the arrhythmias, and in his first session he was teaching us about the approach to bradyarrhythmias and tachyarrhythmias with toxicology, the metabolic acidosis, hepatotoxicity, to cover various kinds of poisonings that we see in India. So we thought that this course is really practical, but it should have a theoretical component. So when you enter the course itself, you should have completed some theoretical training either through lectures or online with a theory test, so that when you enter, you're really going into the simulation training. And the workshop, similar to what he was speaking about, using simulation, some paper cases, and probably for 2 days. And to develop around this a handbook for poisonings, poisoning management for our country, with a certification on course completion and obtaining the requirements for the course. So last year when I went there, he said, I'll come and do the course. So we said, no, you can't come and do the course. You have to come and visit us, meet all our department, understand our situation. So I think Dr. Chih we have been discussing, and 1 year is a reasonable time frame to develop this entire course. And what we're hoping is that this time next year, we should be able to deliver this course, starting with the training of trainers. And what we're looking for is a group of faculty across our respective departments who can run the course, and then at the same time actually offer it to our MD PG students. So this is our hope. And what we need help from is volunteers who are willing to be trainers to develop the course materials as well as to become trainers. So these are some initial thoughts, and we welcome your suggestions and feedback. And before we open for questions, we'll just have those who participated in our mock simulation yesterday to say something. So I'll ask Mithun, who was a student yesterday, to describe the scenario and his own experiences, and then Mana about her experiences as a observer, what you felt about the training, and just quick, brief.
Good morning, everyone. My name is Mithun, and I'm a final year medicine resident, currently posted in the Department of in Medicine 1. So I would first of all like to thank Anand sir for giving me the opportunity to speak today. I was fortunate enough yesterday to be a part of the toxicology simulation we had in the sim lab, and I'm here to speak about the case that we had and my experience as a participant. So the case was actually a 56-year-old male who's a farmer who had a fight with his wife and was found 30 minutes later unconscious in the field and brought to the emergency department for further management. That's the history we got, and the patient had come. There was no relative there to give any further history. So basically, from the class we had on Wednesday, what I understood about as in toxicology or toxidrome management was, first of all, stabilization of the patient. After that, identification of the toxidrome, like sir had said, find out the trunk, the key point, and then try to identify the toxidrome based on that, along with system vital signs and other organ manifestations, and then management of the same, that is antidote and then specific decontamination measures required for the toxidrome. So this patient on examination, the striking feature was that he had bradycardia. His pulse rate when he came in was only, I think it was around 48. So bradycardia, and that was like a slow toxidrome. So the differentials we thought of were like opioid, maybe a calcium channel blocker, beta blocker. But the other vital signs helped to give us a more clearer picture. He was not, his BP was normal, but he was tachypneic and his GCS was low. His sensorium was only 10/15. And examination of eyes revealed pinpoint pupils. So, and general examination revealed that the patient was diaphoretic and he was having noisy breathing. Examination of the lungs revealed conducted sounds. He was also having features of, he had passed urine and stools in the diaper, and while we are examining him, he developed vomiting. So this is a slow toxidrome with evidence of a cholinergic excess. So most probably in the background of a 56-year-old farmer, most probably he had opportunity to take OP organophosphate. So after that, I was sort of relieved. I thought, okay, it's OP. What can be so hard? That's what I was thinking in my head, and we started management. But then I realized that I missed, while I was doing the simulation, and after that, from the feedback I got, I missed specific steps. That is like the decontamination, along with the gastric lavage, a very important step, and also other feedback. Basically, that the examination findings, I didn't go and check the bowel sounds. So all of that. So from the session, what I felt that was really useful, both for it incorporates both what we have already learned about ACLS, and after that it adds toxidrome and the identification of the toxidrome and the management of the same. So it helps you to think on your feet. So it's not just theory, but when you really see a patient, so like sir said in the beginning of the session, that we all learn from patients, but it's better to be prepared, and it helps you think on your feet and then identify your weaknesses and then build upon them and make sure you don't repeat that the next time you actually see a patient. I think it will be a really useful course, because from my experience in medicine over the past 1.5-2 months, realized that toxicology is not what we see. There's a lot of depth to it. It's not just ASV for snake bites or atropine for OP. There's a lot more to it, and I think this course will be really helpful for all postgraduates.
So with regards to the observation part of it, I thought we had the entire, we had at least 5-6 of us as observers. We had both the tools that Dr. Chih had already put up on his presentation. One was a kind of a written thing, scoring and ticking as to what the patient was doing. We also had this very interactive doll with all the like a puzzle where you can actually move things on a magnetic board, so you can push it onto, and the observers were able to actually work alongside, even though Mithun was doing the actual demonstration and being the student there. All the observers were equally involved in walking alongside what Mithun was doing, and also it caused us to think what are the things, because when you're observing, I think we always tend to be a lot more critical, and we know what steps he was missing. And so it was a good way to give that feedback, and then there was a lot of learning that happened as a team. So I think as a training tool, this is very important for us to have all the observers as well involved when there's a case scenario happening, because otherwise usually the observers or the other people tend to tune off. And so I thought that was a very interesting tool. Again, also that little magnetic board, I think it was very, very useful, because once you have your 6 kind of toxidromes in the back of your mind with your vitals and thing, and if you have that up there, as you're moving, you kind of realize, oh, okay, this is what it is. And so you start with, a slow a bradycardia, then myopupil, then diaphoretic, and it all kind of builds up, and then fasciculations and stuff. So it's very easy to kind of quickly say, okay, this is the most likely diagnosis, and helps for intervention. So it's good.
Yeah, so I think we'll open for questions to Dr. Chih. Actually, when we did this, he wasn't prepared for the simulation. So we put him on the spot and said, you have to show us. So he quickly designed this case, and like he just showed us. So we thought it was very simple. Only today I understood, from an educational perspective, you have to think about the starting points, the stopping points, the cues, the checkpoints. So there's a lot that goes into the design, but we did it overnight, I think. And the difference between the ACLS was really how do you actually give that sense of reality. So we went to the canteen and got garlic and for making the garlic odor in the room, and vomiters did some rice and milk and water. We put up signs of the emergency. We had sprayed water on the body to simulate sweating. We had a diaper which was wet. So there are a lot of things that you do to create a reality of the actual situation and the design of the toxidrome. And if you do that enough in many situations, you can train people. So we'll open for questions. Anything else that Dr. Chih would like to add?
Yes, please.
So you undergraduates, who are the participants in your program? Is it faculty from other universities who want to come and learn?
I'm not even. No. Who are the most takers for your course? Is it undergraduates, postgraduates, other faculty who want to come and do the training of trainers?
You mean the students, right? The trainees.
Who attends your courses?
Who are students? Okay. I think we are different from, our system is different from India. We have the internship. After internship, we have a 1 year PGY. And then students go into the residence course. Okay. So this is pretty capacity. Yes. This is, we have this training planned for our own resident. So all emergency residents in Taiwan should take the course, and they need to pass the course before the board exam. Okay. So that's our trainees. And also some young staff, young attending doctor, they will join the course, especially in ASTC. Yeah, in the antidote training courses. Yes, that's, and I also use this in medical students, but not all the courses, not all the cases, because medical students have to learn many, right, and forget it again and again. So this course is to remind them what's the really important things they have already learned or they have not learned. Yes, and so I have 1 hour, I think it's 2 hour teaching lesson in Chang'an University to teach the important things of toxicology. So I ask my students to have deliver their talk. I give them templates, give them the concept of toxicokinetics and toxicodynamics, and they have to prepare their talk, maybe just 10 or 20 minutes, and based on a real case, and they have to present. Okay, so after the presentation, I use the same thing as I used in the simulation course, and ask students to perform there. Okay, and this will immediately enhance the impression they have already talked, not just on the mind, but in the near real world. Yes. Is I okay? Okay.
So Aman only set up the case yesterday, so we'll just ask him. So what did you feel this was different from other simulation training? How did you know Amalraj?
Actually, this toxicology was really a lively one, so that one who comes realizes and analyzes first what to be done first. Even if it is stimulated, but the knowledge comes after the end. While starting, it looks like some ACLS only, but when they go on and on and on, they find each and everything. It's like an investigating step by step by step. The other scenarios will go it is like this is like an adventure. That will be like one fixed journey. That is the difference in this and that. And many classifications of the toxicologies come, but they go in a different way to find out the things. Approaches will be different. Thank you.
I think he's highlighted a very important point that it's actually the diagnostic approach in simile industry. Other comments? Well,
yeah, I think it's very interesting. So you take how many days for this training?
Actually, it's a one-day course for the ASTC, for the toxicology. And it's a 2-day courses for the antitoxin. Okay. But we are now trying to develop this to meet the need of it. So I have discussed with Anna and Rob. So maybe we can have a course here, 1 day for the basic, the classical six toxicology. I already do the kind of another phase for meet the need of it. And I can guide for ratio next.
Thank you. I think as different units with different areas of interest, we are thinking in terms of the educational model, how I'm using it. Particular thing I think is really interesting. And I guess that gives us also a deeper understanding about how we can be meticulous at every step. So really want to thank you for this presentation.
Yeah, welcome.
I think what Sir was suggesting about, I was quite interested by, Sir, what you just suggested, where you do the pathophysiology a few minutes earlier and then the toxodynamics and toxikinetics before and then immediately make them do a simulation case. I think that model is what kind of fascinated me, because I think people do know how to manage, but they don't realize there's so much of pathophysiology behind it, which actually then leads to better management. So I think those kind of cases, do you do it as a part of this course, sir, or what you just mentioned to us, a small talk? Sorry,
So, before we have the simulation training courses, we have other courses. We write a book, a handbook, yeah, and we develop the old school type teaching, just like the lecture in the classroom. So I think every emergency medicine physician should know about the toxicology is covered in the lecture, and it is a 3 days courses. 2 days lecture, and the next day we have a group discussion. Mainly focus on toxicology, tachycardia, toxicology-related bradycardia, snake bites, and one is the high gap metabolic acidosis. So this is the foundation, this is the knowledge foundation for all the emergency medicine residents in Taiwan. Yeah, so and also it is a requirement to pass the exam before they can have to enter the board exam. So Anna and I, we will discuss this in these 2 days. So we will have something like this in here. So we will try to write a handbook, but maybe we can just put this online. Okay, yeah, online. So students can run anytime, and they have to pass.
So it's a compulsory by the government?
Yes.
They can pass.
Actually, we make the rule.
Okay, I wish we had such powers, to make rules.
Because,
You have to, it's essential,
we train our residents.
Sure.
And the Department of Health give our society have the authority to make the rule. Of course, the rule should be recognized by the government.
Of course.
Yes.
So it makes sense. Do you have any way of following up this training? Because you do it for your first year PGs. Do you have any other assessment at the end of their course? Because this is done at the end of first year that they have to pass the exam before the board?
Actually, the medical education in our medical, in Taiwan, in the emergency department, we have several people doing the medical education there.
Sure.
And we have some milestones.
Okay, you'll follow the milestones.
We follow milestone. We also do EPA.
Okay, so based on that, you're able to assess them.
Yes. So every resident have take these surveys in their daily practice.
Okay.
And in my department, we have 2 times of tests every year.
Okay.
And find out what's their weak point. Yes.
So it's ongoing. It's not just with that one exam.
Yes.
Thank you, sir.
So hopefully one of the medical education people will also be coming. Dr. Chih, when we're doing this, he's suggesting that 3 people, one of whom will be from medical education, to come to do the training of trainers next year. But yesterday actually did a very interesting session where it was basically applied toxicokinetics and toxicodynamics. It was really how do we understand algorithms for both for toxidromic diagnosis and management from a perspective of principles. And what we're hoping is to develop the book with these concepts embedded within it, so that the understanding is built in, and so one thing that we're trying to do in simulation is that iterative approach, where you keep doing it, so it becomes sort of embedded in your mind how to go about it, and understanding of principles. So that's very much in the key thing, and the design is also very key. The design of the simulation. So all that work is what will require a year. So thank you, Dr. Chih, for being with our department for all these 4 days. He will be speaking at the CME tomorrow on agrochemical poisoning and snake envenomation tomorrow afternoon. Invite you all to come for the CME program. Please join us for breakfast.